All right, welcome everybody. I am Dawn Ellison, and I'm in the core group of Healthcare Reinvention Collaborative. And our other core members on the call today are Denise Wiseman, Paul Burens, and Jennifer Beach. Today, we have three guests who are sharing about innovations in mental health care. And these are some of the most difficult challenges in healthcare. And these people, these innovators, are working on solutions. So, the format of the event today is that there will be a brief introduction of each of our guests, and then there'll be questions directed at each of our guests on the panel. And then about halfway through, we'll open the floor for a conversation with our participants who have joined us. So that we have plenty of time for our participants to be in conversation with our panel, we will be using a timer. So let me introduce our panel. So Brenda Reiss-Brennan is a psychiatric nurse practitioner and medical anthropologist who pioneered and integrated mental health in primary care. Her 20-year study at Intermountain Healthcare, published in JAMA, demonstrated both clinical effectiveness and cost savings of team-based integrated care. She currently advises the National Academy and collectively with national leaders works to influence CMS policy to fund collaborative whole person primary care teams. Jeremy Fishbach is founder of Happy, a frictionless mental health platform, providing proactive emotional support through non-clinical staff to entire populations. His opt-out model serves major Medicaid plans, the VA, Department of Defense, and large employers, achieving 25 to 40% engagement rates compared to a typical 2 to 6% for traditional mental health EAP services. Jay Subramanian, founder of Doctorite, a technology platform that seamlessly connects primary care physicians with mental health clinicians. Her patented system provides both the technology and the counselors, handling billing and documentation to eliminate barriers that prevent primary care integration with behavioral health. Thank you all for being here. I'd like to start with a chat cascade. So participants and guests, before we dive in, let's hear from you. In the chat, complete this sentence. The biggest barrier preventing people from getting mental health support is fill in the blank. We'll watch these responses come in as we talk. So round one questions. First for Brenda. You discovered that primary care was already functioning as the de facto mental health lab. Patients were bringing their mental health needs alongside physical complaints. How does integration address the fundamental barriers of stigma and access that keep people from getting help?
Hello, everybody. Thank you very much for this opportunity to share with you a very long journey. I've actually been working in primary care for over 40 years. So for the 25 years, I had a mental health integration practice with multidisciplinary teams, and we shared a building with primary care docs in which we had integrated. Intermountain physicians said, please come and help us do this, and then began the journey with Intermountain and helping them look and see what they could do too. But your question was, how does integration address fundamental barriers? And I've been thinking about what actually did we discover about primary care? When we actually went in to take a look at primary care and what was happening there, we discovered that primary care was a home base of trust. And this was a place where families began their conversations about their families and how they were doing and how they were treated as whole. It was a place of sustained relationships and the healing benefit of knowing I'm not alone. And so even though mental health resources in our country have been scarce and depleted for centuries and stigmatized as part of the depletion, primary care became a viable place for people to begin to discover their mental health issues that were connected. So I would like to share with you about that, how we were able to develop mental health integration and the inception of that at Intermountain Healthcare. It actually began with a brave and collective act of reciprocity. In 1998, so this is going back many years, an esteemed community of primary care providers who had just sold their practices to Intermountain, the newly growing medical group business, raised their reputable voices challenging Intermountain and the leadership on their vision for how to improve quality for patients in primary care. Now, many of you may or may not know about Intermountain, but they hold a high bar for quality across the country nationally for quality outcomes in hospital care. But to grow and expand their business in the community of ambulatory care, they needed these trusted providers to be happy. So these were a clinic of reputable primary care docs, by the way, that many of Intermountain leaders took their families to go to, actually had joined Intermountain. But they needed these providers to be happy. But there was just one problem for these top-notch providers: chasing separate diseases like diabetes and asthma were non-negotiable business strategy for them. They collectively declared to Intermountain's leadership that they were on board to improve quality with Brent James for asthma and diabetes, but diseases alone were not the whole of the burden of what was coming into their practices, of their families was struggling with. So they very purposefully said, what are you going to do to help us with the emotional and economic time burden of the domestic violence, substance abuse, anxiety, and depression that our patients present with in their diabetes visit? So in a collective act of leadership, the CEO of the medical group did something quite unexpected in healthcare at the time. She took them seriously. She understood that the most important thing that she could do to improve quality in her health system was to build trusting, continuous relationships with her doctors. She extended an act of reciprocity. She needed them to join her in improving the quality of care for primary care families. And what did they need from her? Mental health integration. She then determined a path forward with them. We're going to make mental health routine. You come in for a sore throat, a diabetes checkup, we're going to check your mental health too. Thus, the inception of a culture of mental health integration with all its delivery complexities, and we are very familiar with many of them, became grounded in relational reciprocity. The CEO redistributed resources for shared attention and a governing strategy and a shared purpose and accountability to provide the conditions for the explicit activation of reciprocity mechanisms of thinking through and working through over time, and I underline over time, the complex, pervasive human dilemma of mental health access inequality, which continues to this day. So in summary, routine medical care, routine mental health, same appointment, same trusting relationships. And that became the inception of how integrating physical and mental health would be carried out, which I'm happy to answer or talk a little bit further about how we did that in the transformation of change and the conditions that we set up.
Thanks, Brenda. You've got so many years of doing this work. There's so much, and I apologize for the short amount of time that we have to give you, but we'll move on to Jay and we'll hear more from you in a bit. So for Jay, you're seeing primary care doctors who want to help with mental health, but are overwhelmed by the complexity. How does your platform address the practical barriers, time, training, billing, follow-up, that prevent willing providers from engaging?
Oh, thank you, Don, for that question. Good afternoon, everybody. Thank you for this opportunity. And I just want to kind of start off by saying I am actually an occupational therapist by background who has worked in the elderly area with geriatric population for a really long time. That's my passion. And with that said, I'll dive into the question you just asked. So, as I moved from being a therapist to being in the health tech space, then always wanted to be an entrepreneur, and then started developing this technology platform within the behavioral health space during the time of COVID, where there was severe sense of isolation, anxiety, depression, and loneliness, specifically amongst elderly and others as well. We realized we were talking to a lot of primary care physicians. One of the things I noticed is, to what Brenda said, she was working in Intermountain Health. There's a lot more support, but there's a lot of independent primary care physicians out there with their own clinics where they don't have that level of support, or they don't know how to access that support, or they're short of that kind of support. So these individual independent owned primary care clinics where we wanted to kind of reach out and kind of network with is where we found the most challenges in terms of how they're able to address more than above and beyond the care that they're able to deliver. And to Brenda's point, they are the trusted first line care providers. However, even though they're trusted and they want to do more, they didn't have that level of access, specifically in behavioral health. One of the main issues was lack of skilled resources, or if they hired somebody, they wouldn't stick on, or they would be used for other work. And then, that there would be inconsistency. The second one was that the patients did not want to be overheard or be judged while they are in the clinic if they had to talk about mental health. That was one of the big things that came out of this conversations and talking to patients and talking to providers. Third was lack of time by the providers. They needed to do oversight. They didn't really have that kind of time. And the primary care physicians were not always very fully equipped to be able to deliver that level of oversight for behavioral health. And then, of course, last but not the least, most of these independent primary care physicians have EHRs, or electronic health record systems, but that doesn't really go deep into the behavioral health to be able to address it effectively. And also, it comes with a certain level of compliance, which they did not know how to go about monitoring, making sure they can bill for these services and get paid for it. So all of these was leading to a lot of inconsistency. Less than 1% of the population receives this care among some Medicare primary Part B patients. Less than 1% receive this care. So that was what the statistics we found. So the way we addressed it was we created a native AI platform. So not just have an AI talk to ChatGPT or anything like that. We built a complete framework of AI within the platform from beginning to end. Number two, the biggest thing that the physicians were afraid of was that they shouldn't get denied for the services they deliver. So we made sure there was an auto audit compliance functionality, which allowed to check to make sure that the call was actually made, because these are all delivered virtually and remotely. And then there was a tracking to ensure that the minutes were met, that there was notes behind it, so they could bill for that care and justify, justification for the care. Third is ability to measure quantifiable outcomes. That was another big one, especially in behavioral health, because when you get a counselor, and within that counselor community, if there is a change of a counselor from one session to the next session, month on month, we needed to make sure they're addressing the issues that are top priority for the patient. So to be able to showcase that to the counselors so they know what they need to address for the patient month on month became very important. So to have a tool or a technology that allows you to see that and quickly address and deliver the care was important. Fourth is we wanted to make sure that the notes that we kind of designed for the patients, the progress is able to be just clinically justifiable, so they can submit it and be compliant. Fifth was that there had to be a safe space. So when you deliver this virtually and remotely, whether it is audio or video, patients were more open to sharing their problems, not just the mental or emotional health, but also about SDOH, about the social determinants of health. So some of them were moving into a car, some of them were losing their home, some of them had roaches in their house, but they were afraid to say to the physician. And they were able to talk about those issues with this counselor remotely and virtually. So that helped address the social determinants of health as well, with the emotional and mental well-being. So these were, and of course, Brenda talked about domestic violence and so on and so forth. It was very very surprising to us. So many of these elderly would actually be so guarded, sharing what they were experiencing at their homes, either with their grandchildren, nephews, nieces, or their spouses. So this was another space for them to be able to share. So all of these kind of led to, and the last but not the least, the ER, going to the ER, or I want to go to the urgent care, or I'm going to the hospital, or I went to the hospital yesterday and I was discharged. There was nothing really they found, was another thing. The level of anxiety that they felt because they didn't get a prescription refilled, or they couldn't get hold of the doctor, or the front office didn't answer, or nobody called them back, or they needed a X-ray or a MRI or whatever. All those were leading to a lot of anxiety because they felt unsupported. So this level of care that they were getting every month consistently allowed them to be in their home and not have to really reach out to some emergency unit, which reduced their visits, reduced the cost, kept them stable, and also increased their patient engagement and satisfaction with their primary care. So they didn't have to switch from one physician to the other. So those
All
were the
right.
ways we addressed it.
Thank you, Jay. And we're still a little bit ahead, so we're okay. But I think I'll move on to Jeremy. Jeremy, your model achieves engagement rates 5 to 10 times higher than the traditional services by making support proactive rather than reactive. What barriers in our current system does your zero-step approach eliminate that others haven't been able to solve?
Yeah. Can you hear me, by the way?
Yep.
Mhm.
Okay. Yeah. Thanks for the invite. And Brenda, Jay, completely agree with everything you shared. I'll just start by framing Happy's view of the world, Dawn, and the audience, because I think sometimes I feel like when we get into conversations about mental health, we're kind of zipping into or zooming into a lot of existing infrastructure. I'll just zoom out for a minute and say that um, Happy's view of the world, and I'm not a clinician, but mostly our team is psychiatrists, psychologists, and people who've been around behavioral health a lot, is that the cause of our mental health crisis is that our primary support systems, where we used to get mental health support, have completely disintegrated to the point where in the 80s, most Americans said they had around three confidants, and now they have zero. Um, and a lot of the support that they were getting, it wasn't CBT, it wasn't psychoanalysis, it was emotional support. It was simply somebody listening to them, comforting them, and encouraging them. And really quickly, when you have 150 million Americans or more suddenly experiencing massive deficits of emotional support, where are they going to go? They're going to go to the only places that exist, which is our traditional mental health system, our traditional healthcare system, which 100% was not built for a societal wide deficit of emotional support. It was built to address much more severe mental health issues. And so what Happy's trying to do is say, we've got tens of millions of people, if not hundreds of millions, clogging this clinical apparatus that was never meant to address this exact problem. We've tried redirecting all those people to apps. That has not worked. They have low single-digit utilization. What is a potential missing layer of support that can provide people with the consistent emotional support that we once had that we're now missing? And the place where we turned to find the answer was by asking people what they want, just to verify our intuitions were correct. And so a team loosely orbiting around the Princeton Psych Department asked hundreds and then thousands of Medicaid members, Medicare members, veterans, physicians, nurses, a simple question most had never been asked: what do you want? The most common answer was somebody like my friends and family checking in on me. They were describing a proactive, non-clinical resource that is nowhere to be found in this country, at least at scale. And so we built it. We built a national network of non-clinical providers. We were completely disregarding how this could bill, or just what would be the best possible network that we could build to provide emotional support exceptionally to large populations. Turned out we were able to recruit thousands of nurses, social workers, people with extensive backgrounds in healthcare. This is not traditional peer support. We screened them for their ability to provide emotional support exceptionally, and then built a whole program around it. And then that's the people of Happy. And the proactive delivery that you alluded to, Dawn, is we hired a bunch of lawyers. lawyers that could remove all the obstacles that prevent most people from getting support, which were put in place by other lawyers in most cases. And to wit, when most people try to get support, they have to be struggling, right? They have to be aware that they're struggling. Most people are not. We don't believe them. We're anxious. They have to reach a breaking point. Obviously, most people never do. They suffer right below that threshold. They have to research their benefits, connect their struggle to a benefit, typically register, opt in, download an app, do self-guided surveys, make an appointment, wait often weeks for an appointment. The models that Brenda and Jay are talking about eliminate some of that friction, but we wanted to eliminate all of it. And the model that we developed, whereby we partner with major Medicaid plans, Medicare plans, the VA, the Department of Defense, large health systems, we get lists of all the people in the population, and then dedicated teams from within our national network, we call them support givers, every month have one job, which is to reach out to by phone and check in on and provide unlimited emotional support, the essential ingredient to mental health for most people, to every single person in the population, unless they've opted out. And to get that support, the end user doesn't have to be struggling or be aware of it. No researching benefits, no downloading an app, no making an appointment, no waiting for an appointment, no limitations on usage, really no stigma, because this is going out to every single person in the population. And the last thing I'll say, Dawn, is I think a general in the Air Force put it best, which is we're finally making mental health like toilet paper, which is just right there. You don't have to ask for it. It's unlimited. And really, if you wanted to to significantly reduce utilization of toilet paper, you could do it. Just take it out of the stalls, make people raise their hand, fill out paperwork. And what we're saying is it should be that easy.
Great, thank you. I'm not sure how my two brothers who are psychologists would feel about being compared to toilet paper, but
I'm talking about Happy's service.
I know. I'm just kidding you. All right. So Brenda, thank you, Jeremy. So Brenda, after 25 years in this field, you've now you're now studying just what works, not only what works, but what social conditions allow solutions to spread. So what's the difference between a successful pilot and systemic change?
So that's a very good question. And I love both Jay and Jeremy's communities and what they've done creatively with the same problem. We share the same problem. We have different ways of fixing it, but we're all working towards the same thing. I think that in order to understand what works, you have to understand the conditions in which people live and work. And so being able to really understand the patient's experience, the staff's experience, the population's experience, and actually do what you both were saying, hear what they say, and what is important to them is not defined exactly the way we actually define it. And I think what we were able to do at Intermountain by really looking at primary care as a bed of trust that's already there, a resource that's depleted as well, to expand that. And how do you expand the trust that's already there without having to go 1 hour at a time with a mental health expert to deal with your life when you have many people that you're talking to in this area? So we did not create a program separate down the hall. Intermountain purposely integrated behavioral health and mental health and physical health, and we invested in people, teams functioning as whole teams to treat whole people. And this really exemplifies the building of a social infrastructure, which I think, Jeremy, you were talking about. What is the network? What is the pathway by which to reach people? And really, it is an equitable culture of everybody pulling together. So we established rules and norms in primary care that everybody does mental health. It's not the job of the mental health expert. It's not just the job of the primary care. Everybody does mental health. The receptionists, the janitor, the MAs, the nurses, the patients and families do mental health. Everybody was responsible and accountable for co-designing and building it, and to pull the resources and team infrastructure together. And there's another piece to this that's really important, is building the governing solutions, not only to say what you need, but to be responsible for it. And that's the responsibility of every team member knowing what their role is, and every other team member having knowledge of other people's role and who to be able to call upon in times of stress. So we built a way to scale mental health beyond one clinic, beyond two clinics, on to multiple clinics within Intermountain in the complexity of infrastructure of healthcare and all the things Jay was talking about, to be able to really also build an economic value for team-based relationships, and that people working together at the highest level of their ability. I won't say licensure, because Jay's talking about anybody has the ability, and that's true if they're willing and operating to be able to do that. But the purpose was a common access to the supply of trusted mental health resources. So 80% of the mental health that was provided in primary care was by the primary care physicians themselves and their support staff. Everyone was trained. Only another level of people needed with their chronic diseases more nurse management or care management or medical home. And then another percent needed the specialist psychiatrist or social worker. But everybody was operationalized at the clinic. It was budgeted, it was paid for. And in 2010, so it's 1998, in 2010, Intermountain realized, was before we published in JAMA, realized this is a pervasive population issue. Psychotherapy and medication is not going to cut what's going on here. It is not adequate with everything that's coming in. And so Intermountain resourced operational support where leaders of the operations team became part of the team. And they actually led the scaling of a robust care process model by which there were key elements where clinics and folks were trained in thinking about normalizing mental health as routine, adopting the actual protocols, which meant they thought their life was ruined and the CEO wanted to make a psychiatry clinic out of them, to where it became routine, where you wouldn't run your clinic without your lab or your mental health. It's like toilet paper. So
there we go back.
It basically became so normalized that you couldn't live without it. And that's what eventually moved the ability with Intermountain's, infrastructure of a great data system to be able to actually track the cost of it, which was $22.19 per patient per year, and the savings to Intermountain as a health system, which was $115.
Right.
And the chief financial officer, when the results came out, said, why are we only doing this in this many clinics? And the answer was because it is an incredible implementation burden. There are the complexities, there are the time, there are the rules, there are the regulations, there are the policies that get in the way of doing that. But nonetheless, we built a scorecard. We built a way for the teams to be accountable and be rewarded for reaching high team-based care. And patients who were exposed to these teams that were operating for all the issues coming in, not just mental health, but diabetes, physical health, they experienced being exposed to high functioning teams, which got us the outcomes that we wanted and the cost. But more importantly than that, in their ethnographic interviews, they also reported that their outcomes, in their words, was, my doctor was the first person to treat me as a whole person. I'm connected to a team that talks to each other, and being on the same page gives me better results. And so the patient's voice was finally brought into the co-design and the operations and the accountability. There is one other operational thing that I think helped scale it beyond 7 clinics, 25 clinics to the whole 200 plus clinics. And that was, we built an operational playbook. How do you actually do the business of integrated team-based care? What does this mean? What does this mean? How does mental health? We used David Satcher's definition of mental health from 1999 mental health report. And we defined what integration was, forming into an organized whole. We gave people a roadmap and built a community of mental health support. We built a support system, and we came together as a retreat every year, and teams presented their cases with their patients and families on what was working, what's not working, and where they were on their scorecard and what were the outcomes. And so it was a yearly retreat. We called it a mental health integration retreat, where teams came together and built new innovations. They built an innovation for domestic violence in GYN clinics. They built an innovation for chronic pain in the primary care clinics. They built an innovation for back pain patients. So clinics were taking the principles of integration and adopting them locally to the population and what the population needed.
Intermountain was definitely on the cutting edge in so many different ways. I'm going to cut to Jeremy. Your model reaches people who aren't struggling or even aware they need support. What does mental health maintenance look like versus mental health treatment?
Yeah. First, just a quick note. I mean, I really love what Brenda just shared, and I'll say that um, a lot of if you just think about the problem, which some people may agree with, some not, as a societal-wide deficit of emotional support driving these challenges. I would just say, I love what Intermountain is doing, what Brenda's sharing, and I would just take it a step further and say where like a lot of our effort is on what we see as the ultimate solution to our mental health crisis, as in there is no other, which is people supporting each other. And once you make mental health simple, let's just say it's emotional support or something like that is the main ingredient. I love the idea of teaching it to everybody in the health system, but then it can't stop there. You need to start teaching everybody in the community. And a lot of what makes Happy's model sustainable for some of our partners, like the Pentagon, is that in reaching out to people and just checking in, providing unlimited support, we're modeling that very behavior so that they can start checking in on the people in their own life. And the most touching thing we hear is when we reach out to an F-16 pilot or a Medicaid member, and they say something like, I got into my car today, and for the first time, instead of putting on a podcast or music, I went through my phone and started checking in on the people in my life. And to answer your direct question, Dawn, you know, a lot of the stories that we've ended up sharing with our partners are the hundreds of people we've reached, thousands who either have a loaded gun in their mouth when we call or close. And they have dozens of free reactive clinical, often, or digital resources available to them. And in those cases, we're directly saving a life. It's either 0 or 1. Without the call, they wouldn't be here. But what really gives us hope is when we reach people who are doing well. And we just actually had reached 3 service members in the Air Force on a vacation. When the call came into one of them, they were all in the car and they all wanted to talk to their support giver. Her name was Krista, and they were doing well. And what they wanted to share with Krista is that they're doing well. And that is preventative mental health. It's reaching people who are already doing well, keeping them in a state of wellness. And when you deliver that service to people who don't need it, now they start to get comfortable with the idea of this type of support. And if they are struggling, now it's even easier to get to support because they're not having to go from 0 to 60. They're already processing their life continuously with a caring person. So I would just say the only way to do preventive mental health is to make mental health like toilet paper. It has to be offered to everyone, not people who are just showing up for primary care or behavioral health, but just to everyone, like a COVID shot. And that's, I guess, fundamentally what we believe has to happen and what we're working toward.
Great. Thanks, Jeremy. So Jay, I love, by the way, that I see all 3 of you nodding your head in agreement with each other. That's just, I love seeing that. So Jay, from the patient's perspective, what's different about getting mental health support through your platform versus traditional referral to a separate behavioral health provider? What's their,
Okay, this is
how's that different for them? I know you're going to love this one, right?
yeah, it's my favorite question. I'm just listening to both Brenda and Jeremy, and I saw the comments in the chat. So much engagement. The access stigma continues to show up surfacing. And to Brenda's point, right, to implement, they had to go through, Intermountain is obviously a large entity, so they had the wherewithal to be able to create that kind of an operational playbook, which then could be rolled out to many clinics. And then to Jeremy's point, right, keep people from getting into the issues, keep them well, let them not go towards downhill, and then try to recover them back. So I look at all these points, and then I look at the clinics that we serve, and the clinics that we want to serve are those independent primary care physicians that are not affiliated currently with one or the other, the Kaisers or the Intermountains of the world. So these clinics again continue to struggle because they don't have the wherewithal to create an operational playbook, the training, the immense level of resource and support and time that they are not able to, and that overwhelms them. Not just overwhelms them, it's very daunting for them. So they try to kind of avoid it, but they want to serve their patients well. So from a patient's perspective, what they see is, oh, I go to my PCP, I really needed this, but the doctor was very busy, so I didn't feel like talking to the doctor or asking him anymore, so I came away. So they have very short time. They're not meaning to be rude or abrupt, but they don't have the time. So this is leaving with the patients a sense of inadequacy in terms of the care that they receive many times. So from the patients, what we hear is, oh, I don't want to talk to the doctor in the exam room about all these things. He was very busy, and I don't like his nurse, or the nurse didn't have time, or they just checked my vitals and they said I'm good to go. So they are not able to have a space to relaxedly share what they need to share. So that's one thing that gets addressed through the platform, because they go home, they don't have to think about transportation, they don't have to think about anything, and they can talk when they have the time. It's not a scheduled where they can only talk between 2 and 3, and maybe some family member is at home, so that access becomes easier, more safer for them. That's one. The second is, we are always as an extension of the clinic. So when they're talking to us internally between the our platform and the clinic, there is always coordination through emails, text, chat, all of that. So the front office, their nurses station, the provider, all of them know where the patient is coming from, what their asks are, what their needs are, what they feel frustrated about. So that communication channel is an ongoing coordinated model. So there is always communication, and if something doesn't get addressed at the front office, the patient are able to call us, we are able to answer it, and that creates an additional sense of security for them. Most importantly, it reduces the stigma of them having to go out and get behavioral health separately, and it reduces the defensiveness of seeking that care. So that's very important for the elderly primarily. And then they also feel like now the trusted partner of that PCP becomes much more tighter for them. Another important thing in the chat I read, insurance payments, approvals, prior authorizations, denials, etc. When you're delivering this care integrally as part of the extension of the clinic, they don't have to worry about insurance payments. Am I going to get approval? Who do I submit this to? I got denied. What does the COB mean? All that worries are reduced for them. So the burden of receiving that care kind of really minimizes. And most importantly, to Jeremy's point, right, keep them well. The overall sense of well-being is enhanced for the patient. That's what we have heard always. And again, the loneliness reduces because they have at least one person, even though it's a stranger, that they can talk to without without the fear of being judged or labeled or anything like that. That's very important, and that's what I think we have been able to accomplish through this.
Thank you, Jay. Thanks to all of our panel guests. We're going to skip that last question that we talked about, but you may want to work it into your conversation with our participants, because we really appreciate the work that you're doing and that you were willing to be here today and share this with our HRC community. And I want to open the floor for discussion with the folks that showed up today. So participants, feel free to unmute or use the chat if you'd like to ask our panelists about their work, share your own experiences, connect with these initiatives, explore how you might get involved. What questions or comments do you have for our panel? I see Rachel.
I'm not even sure where to start. Thank you all. This was a wonderful presentation. I don't think I've met Jeremy, Brenda, or Jay, which is a shame, but we're meeting now. I'm a psychiatrist. I'm in Cleveland, Ohio, and I'm early in my career, so this all matters deeply to me. And you
Mm,
really, each of you touched on issues that are problems I see in our current healthcare system, which really does a terrible job with mental health care in so many ways. And it does a terrible job with the mental part of medical care. Um, and Brenda, you were really speaking to that. I truly believe that there is no such thing as a purely medical or biological illness. Everything we experience in our body is experienced in a psychological context. Even a broken bone, you and I could break the same bone in the same way at the same time. And we might have entirely different subjective experiences based on our psychological context. What do I think about pain? Has pain for me been something that, I bump myself, I keep going, and it just sort of fades and I don't worry about it too much? Or have I developed a chronic pain issue that, it was acute and I wasn't too worried and then it didn't go away and then I was a little bit more worried and then I went to a bunch of doctors and got conflicting information and now I'm very confused, seeking answers, and it's consumed my life. We might have very, very different experiences of this, one acute injury based on that history. So I think we really do a disservice by not making mental health care just a routine part of medical care, not because it must be paired with it, but because it is not separate.
Rachel, Dr. Rachel, I am working with another psychiatrist in Cleveland, Ohio.
Mhm.
Maybe you have heard about him, Dr. Rakesh Ranjan.
Oh,
Um,
yes, yes.
he works, I think he teaches in Cleveland Clinic or
Hmm.
something, I'm not sure. But he has a research center as well. He does a lot of research. And then he has been another advisor for us in terms of how this platform really does enhance. So he's been one of our mentors and advisors to our platform as well. The way we have created the whole fabric underneath it to guide the counselors to be able to deliver consistent care, right? So
Hmm.
sometimes you go to a counselor, you like them or don't like them, the
Hmm.
next time you don't want to go to them, or maybe they took a vacation, they had to go to another counselor. There's a lot of inconsistency that comes out of
Hmm.
it. So we have tried to address
Yeah.
that issue through the platform. So those are the areas where I feel like that also creates additional hurdles
Mhm.
in
Yeah.
terms of accessing the care, sustaining the care, and then to be able to get paid for the care.
Yes. Um, I agree. And when we think about healthcare services, Jeremy's kind of smartly sidestepped that system and delivered a service that is sort of adjacent to but outside of healthcare, where you can bill for that the way you can bill for any service. If you agree to pay for it, I will sell it to you.
Well, I will say we're not. It's a great. Well, yeah, Rachel, great comment in general. I was actually my response was going to be the flip side of what you're saying, that every mental health issue or behavioral health issue has some kind of a physical component too,
Mhm.
because I mean, it's all physical, it's all physiological, but
Yeah.
many people, thousands, tens of thousands of people we're currently supporting who don't feel like they matter are because they don't feel like they matter, even have one, they're at zero. They are ignoring physical health issues are getting, they're simply not even taking care of themselves. They have just lost the impulse to take care of themselves because if I don't matter, who cares if I die of lung cancer? Who cares if I don't eat well? Who cares if I'm drinking Coke 8 times a day? In terms of billing, I'll also say, Happy did start completely outside the system. We were getting paid, just
Hmm.
so out of admin budgets, right? We've had to make
Hmm.
a lot of effort to get into the largest MCOs, medical loss ratios, by using traditional billing codes for this very untraditional service.
Hmm.
That has actually really helped us grow is by, yeah, becoming more traditional on the billing side, even as we've maintained the very different kind of delivery.
I I think that's wonderful. And I'd like to just offer to any of you, if you're looking for more psychiatric advisors, I do have some time.
Sure.
Rachel, I think one of the other things your question is posing that really moves us to where are we going, where have we been, and where are we moving to, is the whole concept of embracing complexity and not seeing it as a barrier, but the whole concept of and mindset of wholeness and complexity and context. And we want to take a disease or take a symptom or take an element here, an element there, and we want to kind of detail it to death, when really being able to step back and look at all the pieces together that need to be integrated and when they need to be integrated, and having a mindset of holding the complex whole, which is what really we were discovering in primary care, that at least for now, that's where all the pieces could be spoken to: the spiritual, the mental, the physical, the family, the community, relational. Everything was relational. And relational and a relational approach to healthcare really speaks to a complex adaptive system that evolves over time and keeps changing. And so new information is going to come in, or new data is going to come in, or new context, or new elements of life. And that needs to be adapted to too. And I think, at least on a national level, behavioral health integration and mental health integration are no longer like the in-fad thing to talk about, because it's not on panels anymore. It's just a part of health now. And so if I look at the 2000, when we had the first Surgeon General's meeting on primary care and mental health, to 25 years later, and look now at the report on whole health, and being able to now define nationally, the academies are defining, well, what does whole health mean? It's all the pieces, it's the context together. And still the problem is we don't pay for whole health. We don't value health. We have a market that thrives on illness and pieces. Jeremy's discussion of the apps, I just loved it. We've built an app for this and an app for that and that. So you have systems that are for-profit and non-for-profit, and then you have communities and people in the way, and being able to move towards how we actually support a whole health approach and have citizens be part of those decisions, I think is going to be, I hope, the wave of the future. Because you all may be aware or not aware, but primary care is shrinking. So that trusted hub of where you go, they're exhausted. Exactly. And the reason is because the United States spends 3% of the GDP on primary care, and the rest is specialty. So if you don't value or fund it or have an economic way to boost trust and pay for trust, then you have a fraying of trust in the institutions. I will say, though, on a positive note, that I never thought in the 25 years since the Surgeon General's office to now, that the new modernization for Medicare CMS is actually changing or proposing to build policies to change the way that they pay for medical appointments and services to actually include relational components of team-based care now.
Oh, really? Wow.
And I'll send to Dawn the input on that, but that is coming soon. And I never thought, the AMA and the medical system has not changed the way they pay for time. It's always, episode. And now putting in a time factor, which is communication, relational, reaching out. It's a baby step, but it's still a step I didn't think would ever happen. And one of the major barriers to the perverse reimbursement structure we have. So thank you for bringing up context.
Well, I think honestly, context is everything. And the social context matters a lot, maybe in the most way. I sort of vacillate between meaning, exercise, and social support as like, which one do I think takes the highest tier of importance in mental wellness? But like you'll notice that in not anywhere in there is medicine.
Yeah.
I I have had a sort of an aspiration for quite a while. I think therapy really is as effective for medical illness as it is for mental illness. And we artificially separate those because we see them one as this distinct separate entity and fail to realize that many, like much of the medical illness we experience is also mental illness and vice versa. And being able to develop a healthier coping style and to change your body's response to illness is in fact treating the illness, usually at least as effectively as most of our medical interventions, if not more so. Sometimes we barely have medical interventions, but like for chronic pain, I mean, opioids. Ugh. But chronic pain rehab programs where there's an intensive, 6 to 8 week multidisciplinary program, people often experience like 70% of pain reduction coming off of their meds. It's amazing.
Yeah.
I think Jay and Jeremy, you started out talking at the same time.
Sorry.
Who would like to go first?
Jeremy, please go ahead.
Yeah, I mean, I was just going to say, we hear a lot of in the conversations like this and others, just how complex the problem can seem to be and how complex the system is. And so many things are complex. And I guess I'll just share our vision of the future really is simple. I mean, we may be wrong, but our simple thesis is that emotional support, just undivided attention, compassion, encouragement is most of what most people get in therapy, get in peer support, get on crisis lines, have gotten from their family. It really is the water, the drinking water, the clean water of mental health. And our simple thesis is that we need more water. There is a drought. People don't need, like, we can't be prioritizing, if we can only prioritize something, making sure that this person has sparkling peach tea and that person has like cherry infused kombucha. People need water. And what I really am inspired by, among all the other things, is when Brenda's talking about the janitor being part of the mental health solution. What I'm hearing is just people need more water, and any way that we can figure out how to deliver that is part of the solution. And the further we get from needing to provide water in overly formal, expensive, friction-filled ways, the closer we are to the ultimate solution of just people supporting each other and this being part of. I mean, I think that the best thing we could do for mental health is teaching emotional support in grade school. We don't hear that come up a lot in conferences where, we're just talking about much more complex issues. And I guess from our perspective, it's how do we get more water into this thirsty population?
Great. I think I'm going to wind us up here because we don't quite have time for one more comment. So let me just get us to the end. Thank you again for all of you to join us today. We healthcare change makers, we aim to understand the root causes and find effective leverage points for transformation. And today's discussion of mental health really helped us to appreciate, these systemic patterns that can inform change across healthcare. Your insights and questions help us to strengthen our collective impact. So thanks everybody for showing up.